in the series. Before I go on to introduce Minister, I'd like to just introduce Alfred Bettini Xuma, in whose memory this memorial lecture is held. Alfred Bettini Xuma has been a neglected figure in the historiography of the South African liberation struggle. Born in 1893 in relative impoverishment in the Nkobo district, Alfred Bettini Xuma's familial roots are in the Eastern Cape. Overcoming great privations, he secured a scholarship to study medicine in the USA, to support his medical studies in the United States. He worked in coal yards and on building sites. He studied at the Tuskegee Institute in Alabama, established by the once enslaved Booker T. Washington. And in 1927, Xuma traveled to Edinburgh, where he received the licentiate of the Royal College of Physicians and Surgeons. He was to follow this 10 years later to receive a diploma in public health from the London School of Hygiene and Tropical Medicine. Xuma opted to practice public health medicine in Sophia Town. His exposure to the socioeconomic conditions of the urban blacks in the 1930s prompted him to investigate and seek solutions to their housing, welfare, education, and particularly the health problems. He submitted detailed memoranda on issues such as the health conditions in Alexandra Township and the lack of compensation for maimed African miners in submission to the 1929 Miners' Pathizis Commission. Xuma's extensive and empirically based public contributions on social policy and in particular health policy since the late 1920s recorded and exposed the appalling conditions of health and welfare of disenfranchised urban Africans. These public contributions in the extent, range and depth are arguably without parallel in South African history. Xuma increasingly identified the denial of political citizenship to blacks as the key obstacle to realization of their social citizenship. This led him to political activism, first as Vice President of the All-African Convention, which was opposed to the removal of blacks from the Cape Franchise, and then as President General of the ANC. The ANC was transformed under Xuma's presidency from a largely moribund petitioning organization into an increasingly mass-based national movement based on paid-up membership with administration and modern democratic constitution. Significantly, the new constitution established under Xuma abolished an upper house of chiefs and accorded women equal membership status to men. In the 1940s, Xuma was impressed with the political acumen and administrative and organizational skills of two high-profile political activists and co-opted them to the national executive of the ANC. These activists were J.B. Marks and Moses Kotane, unionists and members of the Communist Party of South Africa. Years later, in 1947, Xuma initiated the Joint Declaration of Cooperation, or what became known as the Three Doctors Pact. The pact was made between Xuma and leading Indian community leaders, Dr. Naikar and Dr. Yusuf Dadoo, key members of the Natal and Transvaal Indian Congress. The pact promoted non-racial political alliances between the various liberation movements that were opposed to segregation and were campaigning for a full unqualified franchise in South Africa. Although not a socialist, Xuma was nonetheless willing to actively and unequivocally work with those of different progressive ideological persuasions who shared his vision of a non-racial democratic South Africa. What is represented crucially in Xuma's practice, and which was a feature of the ANC under his leadership, was tolerance for different political viewpoints and the de facto encouragement of plurality of political thought, the practice of the civil citizenship he fought for as a right in the segregation era. Xuma is probably most well known for the African Claims document, which set out the nature of the post-segregation new society that would be the fruits of black participation in the anti-fascist war effort on the part of the Allied forces. The committee of leading African intellectuals and political leaders of the time, including Govan Mbeki and Z.K. Matthews, produced the document African Claims in 1943. The document is of considerable political significance in South Africa, as for the first time it unambiguously located full unconditional political enfranchisement as an essential tenet of a post-war society. Prefiguring South Africa's current constitution, African Claims also contained the Bill of Rights. The detailed social rights in health, education and welfare for all citizens were viewed as an obligation of the state to provide. The social rights of citizenship in African Claims included a clause that is the subject of today's memorial lecture. African Claims call for, and I quote, the establishment of a free medical and health service for all sections of the population. The Bill of Rights in African claims represented the most significant statement on universal rights of citizenship, regardless of race, creed, or color, in the period of the 1940s. It was the beacon of the liberation movement and the statement of the liberation movement on the good society. The ideals of African claims were not realized due to the intransigence and repression of the minority white regime in the time. In 1949, Xuma lost the presidency of the ANC and returned to practicing public medicine in Sophiatown. In the apartheid era of the 1950s, Xuma tried to organize his fellow residents of Sophiatown against forced removals. He was eventually forced to sell his family home in 85 Toby Street, Sophiatown, and forced to move to 1401 Mtipa Street, Dube, Soweto. Here he died on the 27th of February 1962 in relative obscurity. The goal championed by Dr. Xuma for free medical and health service in African claims was fully reaffirmed, however, in the Freedom Charter of 1955, the lodestar of the liberation movement led by the African National Congress of Albert Luthuli. The demand of the Freedom Charter was, and I quote, that it would be seeking to establish a preventative health scheme which would be run by the state, and free medical care and hospitalization which would be provided for all, with special care for mothers and young children. If there's one demand that represents the liberation ideal of the oppressed masses of South Africa, it is for a free and universal system of national health care that will meet the needs of all our citizens, in particular the poor, the elderly, and infirm, and mothers and children. In the achievement of this historical objective of the African National Congress, we have a path that runs from African claims through the Freedom Charter and now to the NHI. There could be no more committed a champion to this goal than our Minister of Health, Dr. Motsoaledi. We feel very privileged and honored that Minister Motsoaledi could be with us today. Minister Motsoaledi will be doing this in a time when he is mourning the tragic death of his spokesperson, Mr. Joe Mahela, who served with the Minister since 2012. We extend our deep condolences to the Minister and the family of Mr. Mahela in this time. We are also privileged that Minister could provide us with some precious time under the most severe of time constraints related to commitments on the implementation of the NHI. And Minister has an illustrious history and commitment to both the liberation struggle and the transformation of our healthcare system. He qualified with an MPCHB in Natal at the University of Natal Med School in 1983. He was, as a student activist, National Secretary of the South African Student Congress. In 1981, he was also president of the Student Representative Council at the University of Natal in the year 1982. He was a student leader and a political activist of note who spent most of his political life as a health activist, mostly campaigning for access to quality health care, including pharmaceutical resources for the poor, and especially in marginalized communities and rural areas. This is a minister who knows the grassroots of the experience of the oppressed masses of South Africa. He worked with the entire South African mass democratic movement and the trade union movement in general, particularly in the KwaZulu-Natal region, where he was based. Dr. Motsoaledi served on the leadership of the United Democratic Front in Natal, where he led the student component to the launch of the UDF in Mitchell's Plain on the Cape Flats, where I hail from, in Cape Town in 1983. And Dr. Motsoaledi is also a member and leader, of course, of the ruling African National Congress. He was a member of the Provincial Executive Council of the ANC in Limpopo from 1990 to 2008, a period of 18 years, and served as Deputy Chairperson of the province twice. He was elected to the ANC National Executive Committee in 2007 and re-elected at the 2012 Mangaung Elective Conference. He's also a member of the ANC National Working Committee. He has extensive experience as a provincial minister since 1994, serving as Provincial Minister of Education in the Limpopo government, Provincial Minister of Transport, Provincial Minister of Agriculture, and also Provincial Minister of Education before becoming the Minister of Health. He has extensive experience in the transformation of our government system in ways that suits and meets the needs of our people, and is an eloquent champion not only of African claims but the goals of the Freedom Charter in the venerated tradition of O.R. Tambo, that legendary figure of the ANC and the liberation movement in general. And I think we have no more powerful a champion for transforming our healthcare and handing over the historical torch from Dr. Xuma to our champion of the NHI and a transformed healthcare service, Dr. Motsoaledi, who I now call on to give the 7th Dr. Xuma Memorial Lecture. Thank you.
Thank you very much, Professor Van Niekerk. Let me thank you for the honor of giving me this opportunity to come and address students and academics at this university. Is something I cherish very much, especially at academic institutions. Ever since we started debating the concept of NHI, I get very worried that many people from radio stations write articles in the newspapers about the concept of NHI without actually understanding what it is, or without even engaging us. So I very much value this engagement, and thank you very much. And the fact that I'm also going to give this lecture on NHI in memory of one of the greatest leaders of our people, President Xuma, who was a medical doctor by profession, who also contributed very much, I can claim, as I will indicate later, to the development of this NHI. Firstly, let me start by defining what NHI is, because I think that's the best place to start. Many people believe it's a new form of healthcare system where we are going to abolish private healthcare and force people to go to public hospitals. These are the myths that are going around, and some people actually believe that NHI is not a new system of health. It's about money. It's health. It's about money. It's a healthcare financing system. It doesn't mean under NHI then we're going to say, you know, nobody can go to a private hospital, or private hospitals cannot exist, or private healthcare can't exist. No, it's not about that. It's about money. It's a system whereby we want to pool funds to provide access to good quality health services for all South Africans based on their health needs, irrespective of their socio-economic status. That's what NHI is. Now, this definition, you may as well, if you are very alert, and ask me, what's different from medical aid? Medical aids are doing that. They are pulling funds to provide people access to good quality health services. But there are two words there that becomes a notable difference between NHI and medical aid that make them look like chalk and cheese. The first major difference is that small word there, 3 letters, all. Medical aids do pool funds, yes, to provide access to good quality health services. But it's for a select group of people. It's not for all South Africans. It's for a select group of people. We even know their percentage in the population, 16%. All the medical aids that exist in South Africa are saving only 16% of the population. The other 84% they pretend don't exist. And we've been living with that pretense for too long. And we believe the time has come that that pretense is no longer viable, as I may be able to indicate to you later. So that's a notable difference. It says all South Africans. The second one is irrespective of their socio-economic status. In other words, we are going to give you treatment based on your health needs, irrespective of what your socio-economic status is. Now, even within medical aids, people are still stratified in terms of their income levels, even within the same medical aid scheme. It depends on what your income level is. That will determine the income, the type of treatment you are going to have. And I'm sure you are very much painfully aware of what's wrong with that. In simple language, if you treat people in terms of their socio-economic status, I must, in my office, when my Director General has got hypertension, I must tell her, my Director General, by the way, is a woman, for those who are interested in that. I must say, because you are a Director General, you have got a high blood pressure. Here is your treatment. And then tell her PA, and said, no, you are a PA. You also have the same high blood pressure, but your treatment can't be that. It has to be something else, depending on your affordability. That might sound logical to many people that, yes, if you don't have money, so what? If this person doesn't have money, so what? That might sound logical, but if you look at all international conventions that were ever signed, including the preamble to the founding document of the World Health Organization in 1948, you realize that that's wrong. All the health intervention, or you read the Hippocratic Oath, or you read the Nightingale Pledge, every single document you read about health, you'll find that that type of practice is not allowed. But we're doing it anyway. It's being practiced regardless of the fact that it's not allowed. Even when you go to our own constitution, the newest of the documents, the other documents I'm talking about have been signed many decades ago. But our own constitution, which was only adopted in 1996, it also doesn't say that. In section 27, it says healthcare is a right. Subsection 2 of that section 27 says the state must do everything within its available resources to make sure that this right is realized. It states nothing about socioeconomic status. Subsection 3 of that section 27 simply and clearly states nobody may be refused emergency medical treatment. It doesn't mention about your status in any way. So what you're doing is not based on any document or any agreement. That's why it needs to change. And NHI is going to try and change all that. It's not something that's new, basically. And maybe before going to the past, let me also inform you that this whole concept of NHI, as you can see in paragraph 2 there in the definition, is a substantial policy shift. It's huge. It is something that we have never tried before. And so for that reason, it needs a massive reorganization of the current healthcare system, both public and private. There are quite a number of people who are going to argue, and I like such arguments. I'm sure you are going to engage in them. As we change the healthcare system to suit NHI, I'm told all the time that no, Minister, private healthcare is perfect. There's nothing wrong with it. Don't try to fix what's not damaged. It's perfect. You are running away from your collapsing public healthcare system, as we are always told. Leave private healthcare alone, fix the public healthcare system. Now, that is absolutely not true. Both private healthcare and public healthcare have to be massively reorganized in order for NHI to happen. And that's why I put it in red letters there. There must be a massive reorganization. It has to, in other words, the platform upon which the healthcare system in South Africa is based cannot feed a system where you want all to have good quality healthcare, irrespective of their socioeconomic condition or background. Now, this is not something that is new. Humanity has been trying, especially in South Africa, to do something like this, but very scared to ever do it. I'm saying so because you can go far back in history. You'll find that an attempt has been made to put a healthcare system that is equitable. And of course, some people argue, the moment you say you can treat all people irrespective of their socio-economic status, you are talking communism, which they tell us, look, you know this thing has collapsed. In Eastern Europe, it's not working anywhere. Why do you want us to believe that it must be restarted now and be successful? The story of whether NHI or treating people irrespective of their socio-economic status or not, whether it's communism or not, that issue has been settled long ago. Even before the United Nations adopted this concept, because this concept under United Nations is called universal health coverage. And I'm sure you are aware that in September 2015, the United Nations adopted this concept as one of the 17 Sustainable Development Goals of the world. We just call it NHI in South Africa. But when you go to the World Organization of United Nations, it's called universal health coverage. So it's becoming a world phenomenon. It's no longer South African. Every Minister of Health, believe you me, is settling this problem. How to introduce universal health coverage in their various countries. When we go to the World Health Assembly, where all ministers of health gather once a year in Geneva, we discuss this concept. When we met in August this year in Victoria Falls in Zimbabwe for the World Health Organization Africa regional meetings, one of the main topics was this issue. How do African countries implement this concept of universal health coverage? So even before 2015, before UN adopted it, the concept of whether this is communism or not has been settled and thrown away. In an international conference which was held in Thailand, which I attended in 2011, where a speaker from Taiwan said that there are two economic systems in the world. One is communism or socialism. The other is capitalism. And he went on to outline how citizens get goods and services in a capitalist country. And then outline how citizens acquire goods and services in a communist country. And he mentioned the differences. He then went on to say, but we have now arrived at the point in history where there are two issues in human development where it no longer matters whether you choose to be communist or capitalist. Only two in human life. It is education and health. The state must provide. It doesn't matter whether you are a communist or a capitalist. Now I get very surprised because fees must fall. Yes, fees must fall. And everybody supports that. I get very surprised. Quite the number of people who support fees must fall. When it comes to NHI, they either become dumb or they oppose it. It's two sides of the same coin. And that's what that gentleman from Taiwan was saying. That if you want human beings to develop unimpeded, you must provide them with education and provide them with health. And the state must take that responsibility so that all citizens can equally have access to these two important areas of human development. Otherwise, human beings won't develop. That's why in 2015, when the United Nations adopted these 15 Sustainable Development Goals, this one, universal health coverage, is goal number 3.8 out of those 17 goals. If you read the preamble, they use the word all many times. The word all. And they said nobody is to be left behind in that development. Whether in education or health, or said nobody should be left behind. Otherwise, you cannot then say these are sustainable development goals. So the word all comes there many times. So we're not trying something that it will force you to put yourself in a box and say, no, I can't do this because I'm communist. I can't do that. Meaning both communist and capitalist countries, all of them must implement universal health coverage that is suitable for the conditions of their development. Now, back to the history, as I said, the issue of African claims, when they were mentioned, Dr. Xuma here, where is, you're sitting very far, Johannes. I want you here next to me. Can you change this? Yeah, can you change that for me? Where is your, oh, okay, yes. Where does the issue of African claims come in? As I'm saying, this whole concept of NHI or something like that started long ago. I'm not going to go very far in history. I just want to start with the... No. You got it. Yeah. Yes, stop here. It started as far back as 1928 with the Commission of Old Age Pensions and NHI. 1941 College Commission of Inquiry into NHI, and 1943 African claims that proposed equal treatment in the scheme of social security, and the 1943 to 44 Laxman's National Health Commission that proposed NHI by Dr. Henry Laxman. That was the nearest South Africa really implemented NHI. And the starting point were clinics of primary health care in KwaZulu-Natal, where Professor Kag, who came in from England with his wife, started that process of establishing an equitable health care in primary health care clinics in KwaZulu-Natal. Why don't you ever know about it? Because he attempted in 1944, and in 1948, the National Party came into power. And as you know, the word apartheid and the word all cannot coexist in the same sentence. So it was completely forgotten about. But then in 1945, the Freedom Charter also said something about NHI. Now, if you look at the African claims, remember that the African claims was a document of policy which was adopted by the ANC on the 16th of December 1943, as a reaction to the Atlantic Charter. Those who are students of history, that you may remember that the Prime Minister of Britain during the war, Winston Churchill, and the President of the United States, Franklin D. Roosevelt, met to adopt a document called the Atlantic Charter, which was supposed to define the world after the Second World War. How should the world look like? The problem with that Atlantic Charter, it was pretending Africans don't exist. And that's why there was an objection. And the ANC put together a team under the presidency of Alfred Xuma to put what they call African claims. The African claims are in all spheres of life. So I'm just showing you what they dreamt about in terms of health. They said we need a drastic overhauling and reorganization of the health service of the country, with due emphasis on preventative medicine, with all that implied in modern public sense. Strongly urged the establishment of free medical and health services for all sections of the population, the establishment of a system of school medical service with full staff of medical practitioners, nurses, and other health visitors, increased hospitals and clinic facilities, both in the rural and urban areas, increased facilities for the retraining of African doctors, dentists, nurses, sanitary inspectors, health visitors, and a coordinated control finance of health services for the whole union. That was 14 December 1943. Those of you who are very, very young, you will appreciate that we were not yet the Republic, we were still the Union of South Africa by 1943, because the Republic started only in 1961. So they say for the whole Union, and that was 14 December 1943, when they adopted this. If you read that, and you go and read the United Nations goal number 3.8, you'll marvel at the similarity between what is being dreamed there by United Nations and what was thought about as far back as 1943 under President Alfred Xuma. You see very striking similarities. And of course, people, I'm sure, are cringing. Free medical care, that's a dream. We don't mean free, just like fees must fall. It's not free education. It simply means you don't pay at the point of care. When you say fees must fall, I'm sure you are not dreaming that there's any free education anywhere in the world. You just say when you come to Rhodes University, you must not be required to pay fees. They must be paid somewhere. So when you say free medical care, we also mean that. And at the time when you are sick, you enter a clinic or a doctor's room. Nobody must be demanding money from you. And I get surprised when people say, but this is fine, it won't happen. That's exactly what people with medical aids are enjoying. They don't think about money when they are going to medical aid. Well, you'll argue with me and say no, but sometimes they want you to put core payments, or, when you go to a pharmacy, there is a levy and all that. All those are abnormalities of a system. They were not meant to be. I was a GP for many years. All these things and core levies that have been paid were never there when I was a GP. When somebody has got a medical aid, they never even used to think about a cent. Why are they here? Because it is a system that is unworkable and unsustainable. And somewhere it's going to lead to a collapse. Whether I do anything about NHI or not, the system is not working. That's why by 2002 in South Africa, we had 145 medical aid schemes. Today there are only 83. The others are busy collapsing. They can't keep on with this system. So when they say free medical care, please do understand. They just mean like in medical aid. There must be a source of fund put together somewhere so that citizens don't struggle. And this is the African claims. I've been asking many students about the Freedom Charter, what it says about health, and they said, no, there's nothing about health. About education, of course, every student knows. They'll sing it even when you wake them up. That the doors of learning and culture must be open to all. The land shall be shared among those who work it. The economy backward. Then I said, what about health? They said it's not there. I was very scared. It's actually there, but it doesn't say health. Under the topic, there shall be housing, security, and comfort for all. It says a preventative health scheme shall be run by the state. Free medical care and hospitalization shall be provided for all, with special care for mothers and young children. For all, as I said earlier on, the word all. United Nations is also using the word all. So there was a dream in 1955 that we can have a scheme. And when they say preventative health scheme, it's a very impactful word, by the way, and I want to inform you about that. It's as different from a curative healthcare system, which is what we are having now. Around the whole world, a curative healthcare system has gained currency because it's the most powerful, but it's the most destructive healthcare system that we could ever run. And I was shocked. In the aftermath of Ebola, world leaders are starting to open their eyes that what we are doing is not going to work and it's going to lead to world disaster. Ministers of health never used to be invited to Davos in January every year, where the World Economic Forum is taking place, where captains of industry and academics and leaders of nations gather together everywhere to map the way forward for the economy of the world. They used to believe ministers of health have got nothing to do with the economy of the world. We invited for the first time in 2015, and when I arrived there were only 6 of us. By the following year, we were all over the place, ministers of health. And we were addressed by the president of the World Bank, Dr. Kim Yong-kim, who said the relationship between economic growth and health is no longer up for debate. That debate has been long settled. What is up is how. In other words, when you improve healthcare system, you are also improving the economic health of a country. You are improving the economy. There's no way. In other words, no country can ever stand up and improve their economy if they cannot provide equitable health care to the citizens. Just like if you don't provide education, there will never be economic growth. And so that's what Dr. Kim was saying to us. But then we said, why is it then impossible to provide health care for all the citizens? And the answer is because healthcare systems of the world have thrown away preventative medicine in favor of curative medicine. We have come to believe preventative medicine is inferior type of medicine for the poor. If you are rich, allow yourself to get sick. There will be enough doctors and surgeons to fix you. I'm sure you are aware that's a very stupid concept. Yes, it's like saying, no, I can just stand here in the middle of the road, let any car hit me, they don't fix me. They've got ultrasound machine, MRI theaters, the best surgeons in the world, they'll fix me. It doesn't work that way. But unfortunately, that's a healthcare system that we are following. And as far back as 1955, our forefathers already knew that this is not working. That's why they're saying the state must put up a preventative health scheme. So in the universal health coverage, one of the central issues that we are pushing as ministers of health is this issue of preventative health care around the whole world. Whether we'll be successful or not depends on whether we'll be able to change the mindset of leaders around the world. But as we know now, if we don't change, we'll be in trouble. One indication, not many, how the healthcare system is inextricably bound with the economy is demonstrated in Sierra Leone. The economy of Sierra Leone was growing at 14%. Of course, we're struggling to grow at 0.1%, as you know, here back home. Well, we accept that their economy was very small, but 14% is a huge figure. That economy was growing at 14%. It took 11 months, only, not a year, 11 months of Ebola for that economy to go into negative growth. And it said that it might take 20 years for it to recover. Yes. It collapsed in 11 months because of a virus. If you want me to emphasize that. When they were already at 14, and for them to come back to 14% growth, they say it might take the next 20 years. And the question is, which is scaring world leaders, what if it happens everywhere? What if it goes to the biggest economies in the world and do that and have their economies collapsing within 11 months? What's going to happen to human beings? So the concept of NHI is not only for health, it's also for world security, if you want to put it that way. And these people already knew as far back as 1955. Okay, can we go back? So I just wanted you to link this with history, that we have been knowing these facts. The fact that we're not able to implement them is because of the thinking that if I do this, this is communism, this is not going to work, this is going to collapse the economy. Well, it's the other way around. Now, if you don't understand NHI, because let me warn you, even if you can give me the whole 12 hours here, I won't be able to finish NHI. It's a very complex, long, so I'm going to give you the summary of the summary of the summary of NHI. You still have to go and read and follow up and call more workshops. If you want to call me again, I'm available. I won't get tired because it's not something. The white paper had about 14 versions. We had to draft it 14 times. Every time after drafting it, when we want to take it to cabinet, we go through it, we say, no, doesn't work. We go back and change until the 14th version was the one we said, okay, we can take this out to the public. Every sentence you have to change and couple it together and all that. So it's even now, if I give you the white paper, even at university level, it's very tiresome to read. Because it has got all these very complex, concepts. So that's why I want to warn you that don't think you're going to listen to me once. You'll have an idea of what we're talking about. But if you find things very difficult, this is the conundrum of South Africa, which no other country in the world. And don't think I'm talking an exaggeration. I'm talking that very conscious. This is the conundrum of South Africa, which no other country in the world is faced with. We are the only nation on earth which is faced with what you are seeing on the board. What are you seeing? According to the World Health Organization, a country must spend at least 5% of its gross domestic product on health. I'm not talking about the health budget. Please understand me there. Because if you miss that part, you're no longer going to be able to move with me. They are not talking about the health budget, as the African Union has declared in what is called the Abuja Declaration, which was declared in Abuja, Nigeria, that African countries must spend at least 15% of the total health budget of their country in order to improve their healthcare system. That's not going to work. You can go to many countries around the continent which have met that Abuja Declaration. It's not working. Even if the Minister of Finance was to stand up tomorrow and double the budget of health, it still won't improve our healthcare system. So NHI is not about the health budget. It's about the gross domestic product of a country. And universal health coverage is about that. In other words, it says, in my country, this is how healthy, how wealthy, not healthy. This is how wealthy we are. What amount go to each and every citizen for their health? What amount and in what way and by what form of the whole total wealth of your country is distributed among the citizens equitably. That's what it means when they say spend at least 5% of your GDP on health. Now, when they say if you do that, your health outcomes are likely to be okay, what do they mean? In education, basic education, we know our biggest outcome is metric result, which everybody is waiting for. So what is the biggest outcome in health? The first biggest outcome is life expectancy. How long can people live in our country? The second biggest indicator is maternal mortality. It's not that I don't respect you guys. Yes. You are dead, you guys. It usually doesn't matter, but if it's a woman in pregnancy and childbirth, it matters. It matters a lot. In fact, maternal mortality alone can be an indicator of the level of development in that country before you know any other factor. You just look at the figure of maternal mortality. If it is very high, even if you have never read any history of that country, you know nothing about it, you will just put a figure here of maternal mortality, which is usually measured per 100,000 pregnant women. If you find that figure high, the chances are 99.99% that we are talking of a grossly underdeveloped country that cannot develop. Because no woman is supposed to die while giving birth, but it happens. So maternal mortality is one of the biggest indicators. The other indicator, of course, is child mortality. How many children die before their 5th birthday? And when you finish that, you can add infant mortality. How many children die before their 1st birthday, before they complete 12 months of life? Or neonatal mortality, which is even more obvious. How many babies die within the first 28 days of life? All those figures are health indicators, which according to the World Organization are supposed to change if a country spends 5% of their GDP. If you don't understand the 5% further, an average country in Europe is at 9%, which means in terms of health expenditure as a percentage of the GDP, we are at the same range with Europe as South Africa. But I'm sure you are aware, we dare not even try to dream to compare our healthcare system with what's happening in Europe. They are incomparable, but in terms of expenditure pattern, we are in the same range. If you don't understand the significance of the figure again, because South Africa is not at 5%, is at 8.5%. South Africa is at 8.5%. The same range as Europe, as I'm saying. If you don't understand it, within BRICS, the BRICS countries, I'm sure you know about BRICS countries. Russia is still at 4.5% of their GDP on health. China is still at 4.6%. India is at 4.2%. But all of them have got better health outcomes than us. All those countries I've mentioned. Europe has got better health outcomes. The only country that is mad in the whole planet is the US. They are spending 18.9% of their GDP on health now. And they are about to collapse. So don't be surprised when you see that big war. I'm sure if I were to ask anybody who is the Minister of Health in America, you'll never know. No, because this war on health is at the level of president. You hear about Obamacare and what Trump is saying. There's going to be something called Trump Care very soon. I don't know what it's going to look like, but all I know is going to be a very bad one. Trump Care. Because, yes, the war there in the United States is because it is the only country that is spending that much for health. 18%. It's scary. They are moving towards spending a quarter of their whole economy on health only. So it's a very sensitive topical issue. When Obama was putting what they now nicknamed Obamacare, if you look at it, the title, the official title, is Affordable Health Care. The Affordable Health Care Act in America is nothing but the universal health coverage for America. Because it has to be affordable. It's nothing but the universal health care coverage of America. And we are looking towards what Trump is going to do with a lot of fear and trepidation. Because we don't know what is he going to do. So we are already at 8.5%. I've given you many countries that are not even at that level, but producing better health care. Your next question, what's the problem? Where is the money going to? Where are we failing? And of course, no, we've got a stupid Minister of Health, no, this government, this and that, the clinics are not working, long queues and all that. Of course, that's true. That's true, but what has caused that? The basic reason is that out of that 8.5%, 4.4% goes only to 16% of the population. And the remaining 4.1% must be shared by 84% of the population. Unfortunately, who is the 16% of the population? Unfortunately, I form part of that. And many of you here form part of that. Or you form it by association, if you are still a student. What am I talking about? 16% of the population is the insured population, people who are on medical aids in South Africa. The total amount of money they spend as a gross percentage of the GDP is 4.4. And 84% ordinary South Africans have to spend only 4.1%. Now, human beings follow money. That is the law of nature. Human beings follow resources. Because there is such a huge resource for this 16% of the population. Every available skill is rushing there. Your best specialists, your best nurses, your best health administrators, your best health financiers, your best everything in health is rushing here. Because there's a huge resource. They are running away from here. Because these people here are people with no names, no addresses, no titles. Yes. But we are being told every day now, you must improve them first before you talk about any transformation of the healthcare system. Now, why did I claim we're the only country who have got this conundrum? Because the World Health Organization and the OECD, in February 2016, when they moved from Geneva and Paris to present to former Chief Justice Ngobo, the former Chief Justice has been asked by the Competition Commission to investigate why private healthcare is so expensive. In their presentation, they said South Africa is an outlier he said, you are the only country that is spending so much money for so few people. And you're the only country that is spending so little money for so many people. Nowhere in the world does it happen like that. In fact, when it comes to healthcare, South Africa is more capitalist than US itself. Because yes, US is running a capitalist system, but Barack Obama said, let's leave that capitalism alone and put an affordable health care for all Americans. That's what he was saying. But America is spending that 18.5% of their GDP on at least 51% of their population. We are spending it only on 16%. That's why they are saying we are the only country that can be defined in that way, in that manner. Now, people then come and say, but Minister, this is private money. If this is calculated on the basis of people on medical aid, why then is it your trouble? It's my money. I pay my own money to join medical aid. Why does it trouble you? And it's not my business that my neighbor is poor, by the way. I'm paying tax. Go and help my neighbor and leave me alone. People have told me that openly in meetings. And say, you can't blame me for the poverty of my neighbor. And you can't then force me that we are going to belong to the same scheme. It's unconstitutional, and we are going to challenge you in court. I know already many court cases that are being prepared to challenge NHR. Now, what I want to deal with is it true? Is it factual? Or just emotional trap that this is private money? And I'm here to prove to you that it's not. Why? Let me start with GEMS. GEMS is a medical aid scheme, government employee medical aid scheme. That government employees join, yes, GEMS. Members of GEMS, meaning state employees who are on the GEMS medical aid scheme, are subsidized annually by 2015. These are 2015 figures. I didn't get the 2016 figures or 17 yet. By 2015 figures, members of GEMS are subsidized by the Treasury to the tune of 17,779,102,083 rand. Somebody was swallowing, he thought I was going to trap trick somewhere. Yes. That's not government policy. It's an accident. Because they were saying, no, he's from government. No, it's not government policy. It's just some of the aberrations that happen in this world. Yes. Non-GEMS members, people who are not on GEMS but are working for the state like me, are being subsidized for 1.8 billion. 1,800,000. Who are we talking about here? We are talking about people on GEMS, on permit, on a medical scheme called permit, and permit for the police. Permit is a medical scheme specifically designed for judges and members of parliament. And that in itself is ridiculous. Not even magistrates. Magistrates don't belong to permit. It's judges and members of parliament. They are subsidized for 1.8 billion rand. How many people are we talking about? There are about 265 judges in the country, only. And members of parliament, in Cape Town, there are 490. 90 in the NCOP, 400 in the House of Assembly. And in the provinces, Gauteng has got 86, if I'm not mistaken. KwaZulu-Natal, Tiny Northern Cape has got about 20. So they hardly number 1,000. You should add them. But that's the subsidy. And they're very highly paid. Unfortunately, I'm one of them. I know my share of that 1.8 billion. There's my share there every year. Then SO is the subject of intense debate in South Africa. The state-owned enterprises. It has got people there who earn 5 times more than the president, or more than a president of a country. But they are subsidized for 7,200 million by Treasury. If you watch, the total subsidy is 26,779,102,083 rand. That goes from the Treasury every year. If you are a finance analyst You follow parliament budgets and trends. Even members of parliament don't know about this. I was presenting to them last week and they were shocked because they said, no, I've been in the finance committee for so many years. This I've never seen on the budget. Yes, you'll never see it because it's cleverly done. It's put in each of the salaries of these people who have been subsidized. It's not the budgetary item alone. It goes into your salary on a monthly basis, but when we calculate, it's this much. Then comes tax credits and rebates, which amounts to 20 billion. The tax rebates and credits are for every person who is on a medical aid scheme. It doesn't matter. The subsidies are for government employees. I did not put subsidies here from private companies because I don't know by how much do they subsidize their employees, but I know they do. I'm talking about the state because it's an argument that medical aid is private money. It's not. The state is pushing in 26 billion every year. Now, tax credits are from SARS. Every South African who's on a medical aid does get tax credits at the end of the financial year, and the total 20 billion, meaning a total subsidy from the state, SARS plus treasury, is 46 billion, as you can see there. Now, this is by no means private money. This is very much public money. And it constitutes 1/3 of private healthcare expenditure, which means if the state withdraws 1/3, that's 46 billion. If they withdraw it, we will have drawn 1/3 of the total expenditure of private healthcare, and private healthcare will collapse, definitely. It won't survive, because if that money is withdrawn, it will just be given over to the members of the medical aid scheme. And why am I boldly saying it will collapse? Because for the past 15 years, those who are on medical aid will know. If you don't know, please challenge me. For the past 15 years, your premium to medical aid scheme has been increasing at more than CPEX for the past 15 years, more than consumer price index. And when it does so, increasing at more than consumer price index, your benefits are coming down. Every year they tell you a new law of what they pay for and what they don't pay. And the laws are ridiculous. That I'm sure you know. No, if you come in the morning, you don't pay anything. If you come in the evening, you'll pay 1/3 of 2/5 of the total, you know. No, if you have got this disease, if it is for 3 months, yes, we'll pay 1/3 of 1/8 of that. But if it's just 8 months, 1 day, you know. I'm talking about all these ridiculous things because they were not there. I was a GP. I left my GP practice only in 1994. So before 1994, all these ridiculous laws were not there. They are coming in because the system is collapsing. Bit by bit by bit by bit, regardless of these huge subsidies. Now, if we can't change this, then we can't talk about NHI. If we can't change this state of affairs, and changing this means you are changing an economic system of a country. You are not changing a healthcare system. You are changing an economic system, but which will lead to equitable healthcare. That's why the outgoing director of the World Organization, Dr. Margaret Chan, said if you do this, it's an equalizer between the rich and the poor. That's the summary of defining it. If any country can achieve this, they will have achieved an equalizer between the rich and the poor. Now, I'm going to skip quite a number of slides. I just want to demonstrate to you something very significant, perhaps in your field. When we started to pilot NHI, this new system called NHI, in the preparatory phase, because we said NHI will be undertaken over a 14-year period. The first 5 years, which is ending this year, is the preparatory phase. The next 5 years is to put up structures, and the last 4 years is to implement the actual pooling of funds, whereby we have dealt with this unequal anomaly of subsidies and all that, which I've shown you. So while we were preparing for that, we did what we call school health, we wanted to determine what we call physical barriers to learning. What makes it difficult for school kids to go to school and learn? Is it the stupidity of the child or the teacher or the resources, as people always say? Yes, they are, but what are the physical barriers in the body, in the physical body of that child? We have gone on, and by March this year, we had screened 3.2 million people. By now we've reached 3.5. But when I developed these slides, we had screened 3.2 million school kids. And we found these are the findings. 500,000 of them have got either of these problems. Either an oral health problem, eyesight problem, hearing problem, speech problem. But they are at school and we are waiting for matric results in 12 years' time. And I'm here to inform you it's not going to happen. At least to this number of kids. If you look at the percentage, it's 15% of school-going kids in South Africa either have got oral health problem or eyesight problem or a hearing problem or a speech problem. And the teachers reach one conclusion: dull, stupid, moron. That's the only condition that teachers can reach because they don't know. Some of these kids themselves believe they are dull. They don't know that they've got this problem. It's 15%. But what is more disturbing is 15% when we take all the schools in the country. In the first 18 months, we're doing the study in quintile 1 and quintile 2 schools. The poorest. If you go to the poorest schools of South Africa, it's not 15%, it's 33%. 1 out of every 3 school-going kid has got this type of problem. How does it relate to NHI? Because we are unable to correct it. Because they don't belong to that 16%. There are no resources in the country to correct it. Just to give you an example, these ones need spectacles in order for them to see what's happening on the chalkboard. They need spectacles. There are only 3,000 optometrists in the whole of South Africa. And only 250 of them are available to public health care. Meaning out of the 3,000, only 250 are available for that 84% of the population. The rest are available to the 16% of the population. That's our problem in this regard. Now, I'm giving you a figure of 500,000 there out of 3.2 million. But the total number of school-going kids is 12 million. If you do your mathematics and project, you realize that if it's 12 million here, then there it must be about 3 million. So we've got 3 million human beings going to school every day, unable to learn because this problem has not been solved. And so when we talk about NHI, we practically want to solve problems like those. Now, State South Africa, if we talk about consolidating present finances, State South Africa has divided the country, the population, into 5 groups. The first group there are individuals in households with no income or who are unemployed. These are your elderly with no income, children, the 12 million school-going kids, the unemployed, and the unemployable. They number 24 million. The second group are people in the informal sector. They and together with their dependents. These are domestic workers, hawkers, taxi, industry, and casual laborers. They number 8 million. The third group are in the formal sector, but in the SMME, small, medium, and micro enterprises. They number 6 million. The third group are in big business, big employers. They number 12 million. And the last group are civil servants and their dependents. Government employees, state-owned enterprises, public entities, they number 5.5 million. Now, this group are not insured at all. There's no possibility of them ever having a medical aid. It's impossible. This group is not homogeneous at all. Some are on medical aid, others are not, depending on your individual income. If you are working for the state or what private employer, medical aids don't just come easily. You have got to earn a certain threshold. You have got to reach a certain threshold in income. So we don't know how many yet, but some have got, others do not have. Now we are saying, because these are already covered by medical aid, perhaps in the beginning, when we implement NHR, we must leave them as they are, just for now. Not because they said I must leave private healthcare alone, just for now. And go to these ones and pick them up and do what with them. We can give them basic services, not everything. Basic services that will make them worthwhile citizens of the country. And this is what we have done. We've divided them into groups. Let me not reach, let me leave that one and come here. The first group are learners at school. I've already told you, there are 12 million of them. What can we do for them? They need pets, they need an oral hygienist, they need a speech therapist, they need hearing aids, etc., etc. The state can provide that for them. The second group, we said maternal and women's health. Now, I want you to be very careful here. The learners there who need spectacles, etc., as you can see, will depend mostly on whether they've got problems of eyesight, hearing, etc. Now, on maternal health and human health, and women's health, we don't want to discriminate in terms of socio-economic conditions. Women have got problems whether they are rich or poor, and many people may not know that. I'll just give you one small example later. Why even rich women, when it comes to women's health, suffer, leading to all these complications in the development of a nation. What we want to do for them, we believe every pregnant woman in South Africa, regardless of their socio-economic status, can be given a package that takes her through the pregnancy and childbirth in a way that is beneficial for her and for the unborn child, to give that child a head start in life. Because many of us start deciding or start determining the destiny of our fellow citizens by the time they enter school or university. We start defining your destiny. Your destiny is defined here, while you are still waiting inside here. Your destiny is already being defined. And that we've always been ignoring. So we want to give every pregnant woman, according to this plan, because we know their number. There are 1.2 pregnant women in South Africa every year. If you think we have got a big problem, go to China. They've got 67 million pregnant women every year that they must take care of. But according to the size of their population, obviously. So the 1.2 million pregnant women, each one of them can be given a package to take them through their pregnancy and childbirth. What is the package? It's 8 visits to a doctor, not a specialist, at primary health care, and of course a specialist if she's referred, if there's a complication. But for a normal pregnancy, each woman can go and see a doctor 8 times throughout the pregnancy, and 2 times of which an ultrasound must be done to see if she's carrying a normal baby. At the moment, ultrasound is only for the rich. Many women, we don't know what they are carrying because we don't have ultrasounds in clinics, etc. But we want to do that at 12 weeks and 22 weeks. And that's very important. In South Africa, pregnant women don't see a doctor 8 times a year, or don't have an ultrasound 2 times. Those who are on medical aid, they can have ultrasound 100 times if you choose, because it has got nothing to do with health. It has got to do with your medical aid. Yes. If you want more money at the ATM, you go many times to the ATM. Yes. So if you want more money from the medical aid of a woman, just keep on threatening her about her baby, that you need another ultrasound. next week. You need an ultrasound in 2 weeks' time. That's not true in most cases. Where do we take aid from? It's a figure issued by the World Health Organization. They said a normal pregnancy anywhere in the world can be achieved if a woman is seen 8 times by a qualified doctor throughout the course of the pregnancy, and 2 times at 12 weeks and 22 or 24 weeks, an ultrasound is done. Only when there are complications, you start doing many other things. So we want to do that standard for every woman. Then we can give every woman free contraception and family planning, which we have been trying sporadically. But we can also screen and treat for breast cancer and cervical cancer. The biggest killer, I was listening to SAFM this morning as I was driving from Port Elizabeth here. There was a topic about breast cancer. What has happened? Why is it so prevalent already? Have we done anything wrong? Is the state doing nothing? The fact remains, as I'm standing here in front of you, there are 5 cancers that are annihilating us. I have been in medicine for the past 34 years. I've never seen so many people suffering from cancer. It's scary. I don't want to scare you. I'm just giving you facts. In fact, our new HIV/AIDS is becoming cancer. Very soon, in 2030, we believe HIV/AIDS will be under control. But these ones are on the rise. At the moment, 5 cancers are annihilating the nation. It's breast cancer in women. It's cervical cancer in women. Fortunately, we've got a vaccine. I'm sure you are aware that from 2014, all school girls, when they reach 9 years or grade 4, we give them an Hpv vaccine, meaning we are solving it for the future. For now, we can only rely on screening, chemotherapy, and radiotherapy, but that's cervical cancer. So in future, it might not be a problem when these young girls become adults. But for now, it's still a big problem. The third one is lung cancer for all the sexes, but mostly in males, because they are the ones who are pumping smoke into their lungs at every available opportunity. Then we've got prostate cancer in men. And the last one is colorectal cancer. You hear a lot about it over the media, that so-and-so has got colorectal cancer. And they've gone down in age. During my days at medical school, we considered cancer to be largely for older people. It's no longer the case, believe you me. Believe you me. Men, please, make it a habit to go and check prostate cancer. Make it a habit, especially once you reach 40. If your first-degree relative has got prostate cancer, your chances of getting it are 40%. If one first-degree relative, your chance of getting it are 40%. If a second first-degree relative gets it, your chances jump to 80%. Unfortunately, that's where I am. Me and my brothers, my siblings, who are males. Because my uncle, my father's elder brother, died of prostate cancer in 1992. My own father died of prostate cancer in 1997. So my chances are 80%. And I'm just sitting and waiting. That's how life is. So you need to know that these are unpalatable but true facts of life. That 5 cancers are finishing us. So when you see me running around complaining about smoking, alcohol, sugar, and people say we are becoming a nanny state, I'm scared, man. We're dying. It's not about being a nanny state, it's to protect the public. We're dying. Because all those things we must deal with are risk factors in these cancers. Smoking, alcohol, poor diet, especially sugar. Sugar has become a new poison you can't believe. And people are challenging me that, no, this is just a scam. Sugar has been there for ages and ages. It was never a problem. Why is it a problem now? It is a problem. In cancer, it's a problem. In high blood pressure, it's a problem. In diabetes, it's a problem in obesity. And when did it start being a poison? it's not sugar that is a poison. It's human beings that have made sugar a poison. You give a dog a bad name, you're going to have to hang it. What am I talking about? When I was young, I come from Skukune, one of the most rural areas of Limpopo. All these sugary things, chocolate, custard, jelly, we used to see them only once on Christmas Day. Then we see them the next Christmas. These young ones don't know that, yes, they believe I'm mad. Honestly, yes. There were all these drinks, Coca-Cola, they were not there, man. We used to buy Exa and cook it and put it in a first house to try and make it cold. Then after Exa, we developed into Kool-Aid, which has sugar inside it. Then all of a sudden, there is Coke, there is Sprite, everything. No longer on Christmas. It moved from Christmas to weddings. It moved from weddings to funerals. It moved from funerals to every Sunday. It moved to every Sunday to every meal. And I was asking people, a can of Coke, a 330 ml can of Coke, has got 9 teaspoons of sugar. And people readily drink it. And I was telling some mothers, if you are in this room, you are a VIP, we give you a can of Coke, you drink and you enjoy it. When you go home and find your child with 9 teaspoons of sugar in a hand leaking, you're going to assault that child. They say, what he's doing is madness. That's exactly what we have just done. You have done a madness but in a sophisticated way. And this child is doing the same madness but crudely, by just going into the sugar pot and grab 9 teaspoons of sugar and start leaking. That's what we have done. Because there's nothing in Coke except that sugar and carbon dioxide and flavorants. That's all. But the price we are paying, you know, I got very scared. Last week there was an article in the Star of a young surgeon at Charlotte McGregor Hospital who was announcing to the nation that please the government must do something. He said the ward at Charlotte McGregor Hospital where he's putting people with amputations, there's no more space. Amputations from diabetes. I'm sure, yes, he said there's no more space, it's full. And he was saying, please help. He then said, when I was a young medical student, there were people who were amputated here and there. When I qualified as a surgeon, the number seemed to have been increasing. He said, now it's an explosion. I have got no space, I don't know where to put them. All of them coming, chuk, chuk. We have got to cut their legs. This is what we're talking about. So what do we do? In a typical curative healthcare system, you increase and they will tell, no, you must build more wards and put more resources. This is what I'm told every day. Same as I tell people about kidneys. Do you know how many South Africans suddenly need new kidneys? It's scary. How do I know? Because whether you go to a public or private hospital to do a kidney transplant, you can't do it until I've approved it. I have to sign. It's not because I'm very powerful, simply because I'm a minister of health. And because kidneys were being stolen, I just want to see if yours is not stolen, it's a donation. So I approve them. They go through my desk every week. And it's scary. It's even more scary because our neighbors in SADC, none of them can do a kidney transplant. They all do them here. So even for them, I have to sign. No, they don't have facilities for these transplants. They all come here. But it's scary. And what causes that? High blood pressure. Contributing factors, salt and sugar. With salt, we've already given guidance in 6 foodstuffs. Bread, brine, chicken, soups, etc. We've already given deadlines to industry to reduce the amount of salt. The first target was 2016. That's last year. Our next target is 2019. That those must have lesser salt. There was not a lot of noise. There's a lot of noise about sugar. Because Coca-Cola is a very powerful company and they've made me their enemy. And I told them I'm not prepared to be their friend anyway. Not when there's so much suffering. So cancers. Now, I spoke about rich women. There's a new drug for breast cancer. Well, it's unfortunately, it doesn't treat all types of women, but for those who fall within a category that category is determined by your genes. A new breast cancer called Herceptin, Trastuzumab, Herceptin. It costs 24,000 rand a dose. And the cost of treatment for breast cancer is 17 doses. So we are asking South African women to pay 24,000 rand times 17. Just show me how many in this country will achieve that. But we are going to do it if this program gets off the ground. I'm saying if, because I'm still living in front of Treasury to convince them that this is in their interest. Because we would like every woman who has got breast cancer, who qualifies in terms of their gene, to get Herceptin. But believe you me, I am not, and underline that, I am not prepared to go and get it for 24,000 rand times 17. Why? Because that's arbitrary. The cost of private healthcare in this country is very arbitrary. It's not real. If you go to a private hospital and ask for a circumcision, you're going to pay 7,000 rand. But the GP can do the same thing for 850 rand. The American funder, PEPFAR, is paying doctors all over the country to do circumcision for 450 rand. But in a private hospital, it's going to be 7,000. Why? Because when you arrive there, they look for a urologist, a specialist who trained for 13 years. Then they look for an anesthetist, another specialist who trained for 13 years. Then they look for an assistant, who is a doctor like me, who trained for 6 years. We, the smaller ones at the bottom. 3 people who are highly trained at university to come and sit at one man's penis just to remove the skin, so that it costs 7,000. That's absolute madness. What is happening in the private sector here? Same as this maternal health. This maternal health, where women have to go and do a so on and all that. We are also adding Caesar, but at normal rate. What is the normal rate? Globally, the rate of cesarean section is 15%, meaning 15% of pregnant women might have problems in delivering a baby in a natural way. They need a Caesar, 15%. In the private health sector in South Africa, it is 70%. 70% of women can no longer deliver. Normally, I'm sure you have gone there, you've seen. Don't think it has got anything to do with your health. Of course, they'll convince you 100 times. It's because somebody wants to go and play tennis, somebody has got the banquet in the evening, another one wants to go to the golf course. But more than anything else, a woman who is in labor may be taken care of for 10 months, for 10 hours soon. Labor can take 10 hours, up to 12 hours. And in the modern commercial medicine, it's a waste of time to take care of one person for 10 hours, when you can go and remove the baby and rush and take care of others. That's the system we want to change, because it's wrong. Then mental health. You heard about life is remaining. A very serious tragedy, which should not have happened in this country. But it has happened, and we see no more. Something like that. Every day I listen that we're doing it to save money, I run mad. Because that's not what the healthcare system is not about. You don't save money in the healthcare system and sacrifice people. It's the other way around. And so that's why it horrifies me what has happened in Gauteng, but we want to take care of mentally ill patients. Screening, referral, and care. Then the elderly. As I'm speaking in front of you, we have got 270,000 elderly people who have gone blind. Now, all they need is a 15-minute cataract operation. They will see again immediately. Get into theater for 15 minutes, they remove that cataract, cover the eye, release you in the afternoon, the following day you open the eyes, there. The world is open again for you. It needs only 15 minutes. Why can't we do it? Because the 270,000 is the backlog. Because I told you money follow people. All the specialists and facilities that can do that are not available. for 84% of the population. So these people I'm giving you about belong to the 84%. They've got to have somebody to take care of them. What a wonderful world it will be when you wake up one day, find that you don't have to take care of your grandmother. She can be independent, she can read the Bible, she can take care of your baby when you go to work. She doesn't need to be taken care of because once more she can see. And these things are possible because people keep on saying it's madness. In England, under NHS, because the British government has been having the NHS from 1948, 69 years now, that they've been having this system. They also have a backlog on cataract. They came and asked a South African company, Netcare, one of the big three private hospitals, to deal with that backlog. And how much are they being charged? Not the madness that is happening here. They are being paid for by a price which is set by the British government, which is the same as what they pay all their public hospitals. And they say, take or you go. You either will do this cataract for this much. So I'm just giving this warning that that's what we're going to do about NHI. We're not going to ban public hospitals or start chasing them. We're just going to say, okay, if you under NHI you want to do a circumcision or a cataract, let me give you an example of a circumcision. You can go. If you want to do it in a private hospital, okay. If you want to do it public, okay. But we are only prepared to pay $850, not $7,000. Full stop. If you want to do a Caesar as a woman, can go and do it. We're prepared to pay, but we'll pay only this much. Not all the other amounts that are being mentioned there, which we know are ridiculous and arbitrary. Then the disabled, I'm sure it's very obvious what the disabled need. We have calculated their numbers over the next 4 years. We have calculated how much it will need to do all that. If you calculate, it's a figure of 14 billion. If you look at all those figures, 80% goes only for women. All these other children at school, the disabled, the elderly, all of them will only need 20% of that money. The whole 80% is going to women. And that's not by accident, because I told you, pregnancy and childbirth determine the destiny of a nation. Yes. And I've been in health for so long and in government for so long that I know it. Nothing against you guys. When HIV/AIDS started hitting very hard, we saw the effect of it. If in a family, a newly married couple, if it is the husband who passes on, the wife can hold on, can hold the family together. And you might notice there's a problem by the hold it. If it's the wife who passes on, the husband gets completely disorientated, completely. They start drinking, they start doing things that they've never done before. They just completely change their character. So men cannot hold on if their wives are gone early on in life. It's women who can do that. So that's why we need to take care of them. Yes. And no, that's true. That's true. It's just so much a living fact. In the rural areas where there's migrant labor system, the future destiny of a child is not determined on who their father is. It very much depends on who their mother is.
Yes.
Yes. Then you know that this child. No, it doesn't. Yeah, I can see some guys are shaking their head. I worked in a rural area, Baba. There are men who don't even know their children. They don't know how many they've got. And I've lived through it. When I started my practice, my landlord, who gave me premises, one day came holding a baby. It was a grandchild. And he was swearing at the wife, "Yo, man, I just came last night, I was away. And this woman is not taking care of the child, man. Doctor, please come and check this child for me." I was just starting my practice, so I didn't have a receptionist. I was doing everything myself. Then I took the new file and started asking, "What's the name of the child?" He said, "Oh, let me go to ask this woman. How? But you were swearing at this woman that she's careless, she can't take care of the child. Now you don't even know the name of the child. Then we visited a chief one day as we entered there. The child came out crying. Baba, please, I'm asking for 5 rand. And he said, who's your mother? The child told him, he said, oh. So he asked, hey, why do you ask this child who their mother is? He said, no, I don't know them. I've got 48 of them. I only know their mothers. So for me to know which one is this, they must give me the name of the mother. Now, yes, so I want you to understand why I'm saying all these things about women. That giving them 80% of that share, it's not something that we're just doing idly by accident. It's because the beginning of life, the foundation of our lives, lie in the survival of this woman. I'm sure you have heard about the concept of the first 1,000 days. Americans, because they are rich, they've already done it. That we must give a package for a woman if we want development. If you want your country to develop very fast, you must give a package for the first 1,000 days. Meaning what? From the day the woman's pregnancy is diagnosed until the child is 2 years old. Those are the most crucial years in development of a human being. And that's what we're trying to achieve in a small way there. Now, where do we get this money from? Of course, I went to Treasury. And they said, yeah, no, the economy is quite bad. I know that. But these people need help. But then I said, Treasury, if you don't have money, just give me an answer to this. Can you give me the economic, social, political, or whatever reason why there is 20 billion rand that comes back to rich people like me? Can the Treasury explain that to me? The minister was Pravin Gordon at that time. He was as surprised as me. He said, what? I said, no, Minister, there's something like this. There is a tax rebate. And I want to know its meaning. And he realized that the matter was never discussed. Called one of the officials and asked him right there in front of me. He said, no, Minister, this thing started during the apartheid era. The government then thought, and wrongly so, by the way, it thought that if you encourage as many citizens as possible to join a medical aid and give them a subsidy and incentivize them through tax credits, then many citizens will be enticed towards joining a medical aid. And when they do so, when they are sick, they'll go and buy their own health. They won't trouble the state. In other words, the state doesn't even have to know that so and so is sick. You just give them this, and you give them that, and forget about them. Maybe you'll hear maybe one day when they need a death certificate. That's when the state comes in. But throughout their health, the state doesn't come in. Why did I say wrongly? Because that concept is wrong. Because it's not practical. No human being living within the borders of any country can go on in life providing their own health without the state. It's not possible. But it's not even happening now. Which means this money is going to people based on a completely wrong concept. Completely wrong, that doesn't happen. I'll just give you 3 examples, maybe 4, if necessary. Number 1, let's look at the biggest killer, HIV/AIDS. There are 3.9 million people who are on ARVs in South Africa. 3.9 million. This huge amount here is treating only 280,000 of them. Only 280,000 are treated by this huge amount. The rest of the millions have to be treated here. That's number 1. I just gave you an example of pregnant women. 1.2 million of them. This huge amount is taking care of only 140,000. There are only 140,000 babies born in private hospitals in South Africa. 1,060,000, they must be born here. Then comes TB, which overtook HIV/AIDS as number 1 killer in South Africa at least, by 2014, TB became #1 killer. How many people are we treating? We're treating 300,000 every year. Private sector, 0. Not a single one. The fourth reason, if you want to know, all of you who are on medical aid, even if you are in ICU, if your money gets depleted, they'll send you to the public sector immediately. Even when you are in coma, by the way. There's no time to wait. Yes. Even when you are in coma, by the way, they will do so. Local. We experience that every day. So in other words, I'm trying to argue that this money is wrongly placed. I am demanding it, that it stops in the name of equity and equality. And it comes here. By the 4th year, we'll be needing 69 billion, but the tax credits given back to the rich will have reached 80 billion. And I only want 69 billion of that to help these people. This is what I'm fighting for. And I've been told or threatened with an uprising of the black middle class, the middle class. It's okay. I was even asked whether COSATU will allow that. I went to confront them and ask them, you want NHI? Are you aware that you are likely to lose this so-called tax credit? Because they are wrongly placed. They are wrong. Very wrong. Extremely wrong. Let's look at medical aids themselves. This is GEMS again. Medical aids, because they are in trouble, they've done something which, as I said, when I was a GP, was not there. They are trying to stratify people in terms of income. GEMS have got 5 options, all of them depending on how much you earn. Discovery has got 16 options, meaning their treatment options are 16 different ones. In GEMS, they named them after precious stones, sapphire, beryl, ruby, and all that. Sapphire, you can only go to see a doctor 3 times per year. In other words, don't get sick more than 3 times a year. It's a sin. You're going to suffer. Each family member 3 times a year. And when you are sick, when you are on sapphire, you can only go to a public hospital. But the tax credits are saying you were given a medical scheme in order to go and buy your health care elsewhere. Not true. How many people are on sapphire in the public service? 40,450. And the state is subsidizing them for 333%, which is very, very wrong. Now, I am demonstrating, I have been told that NHI is going to be extremely expensive and unaffordable. But all the indications are not that. And what are the indications? Ever since we started talking about NHI, we've been negotiating very hard. And we're using economies of scale, and they are very successful. The Hpv vaccine, which we are giving in schools, if you go to a private sector and buy it, it will cost you 730 rand per dose. But I went to that company and said, look, I'm going to give you 500,000 school kids per annum for life. I can't buy it for 730 rand per dose. How much are we buying it for? 139 rand. That's why we're able to cover all the school kids. Pregnancy, we have got a subdermal implant, which we introduced in 2014, where we implant a small gadget, like the lid of a pencil, just below the skin, under your axil, under your armpit. It costs 2,394. Then we went to the company and said, no ways. How many women would like to prevent their pregnancy for this much in the general population? Especially 84% of the population. We are now buying it for 115 rand because we give them 1 million women. So these things are possible. I can go to ARVs, etc., etc. I don't want to go there. For NHI to happen, these are the acts that Parliament will have to amend when we develop an NHI bill. We must amend the National Health Act, the Mental Health Act, the Occupational Disease in Mines and Works Act, the Health Professions Act, all of those, they need to be. I can't go through all of them, it will take a lot of time. But there are important ones there. This, which I just want to touch before I finish. The Provincial Health Act. The provincialization of health in the country has caused havoc. Life is Demand is one good example. That's why the UMPAC said the National Health Act must change and the Mental Health Act must change to avoid demands of the future. What is he talking about? This is where we want to change. The difference between private health care and public health care in quality is that private health care has clearly deleted functions. There are two arms to private health care. You have got a purchaser and a provider. There are two different individuals. The provider is a person who provides health. It might be a specialist, a private hospital, a GP. They provide health services to you. The purchaser is your medical aid scheme. The medical aid scheme goes and says, go and get services from the provider. We will pay the provider on your behalf. Now, in that scheme of things, the provider is forced, whether they like it or not, they are forced to provide quality. Because the purchaser won't just come and buy. They will have options elsewhere. So if you are a provider, you are under that scheme, you are forced by the nature of the business to provide quality. Even if you did not dream about it, you are forced. Otherwise, you are out. Now, in the public sector, it's different. The provider and the purchaser are one and the same person. In our present healthcare system is the MEC for health. He or she is a provider and a purchaser at the same time. What do I mean? He or she is given a budget to go and provide services, build clinics, hospitals, equip them, hire doctors, hire nurses, pay them, put medicines inside, run the ambulance service, etc. That's the budget they are given. But then they use the same budget to buy services for that 84% of the population. That system is not guaranteed of quality because you are buying what you are providing yourself. In other words, even if you provide rotten goods, you are the one who's going to buy them anyway. So what? Even if you provide rotten magwinya and all that, you'll still buy them. You won't worry about it because you are the buyer and the provider at the same time. Now, in this act, we're going to split that. We're going to split the purchaser provider just like in the private sector. MECs will be given a budget, but the districts will become buyers. They will become purchasers, will form a district health system. And the districts have got different disease profiles. People in Sandton are completely different from people in my home area of Sukune in terms of their health profile. Then the district will decide, where do I buy the services? The MEC here is not doing well. I can't buy this service here. There's a private entity there that's providing better services. I'm going there. Then the MEC will have to explain to the nation why the NHI can't purchase services from them. Then the nation will become a push. So that's what we're going to change there. The other is various ambulance legislations, emergency medical services. Our emergency medical services are in tatters. 3 years ago, we asked Professor Lee Wallis. Professor Lee Wallis is the head of emergency medical services at UCT. We gave him a team of people. They went around the world for 3 years, looking around how the world conducts emergency medical services. They came with 3 recommendations. Recommendation number 1, all ambulances, regardless of who owns them, must have one color. Same color, which citizens can identify. Number 2, when a South African phones an ambulance, the number must be 1. There must not be multiple numbers like now. I've had many people dying and claiming that the relatives claiming that the ambulance didn't come. When we investigate, they found the wrong one. The one that they don't belong to. Because they don't, yes. So there must be one number. And once the number comes in, the ambulance nearest to the scene of the accident must go there. Or otherwise you don't get the license. Because we've got many instances where people die because there's an accident, you are on the middle of the road, you are bleeding. When I was at medical school, they told us when there's an accident, the person is bleeding, you do ABC. You check the airway, then you check the breathing, and you check the circulation by checking the pulse. That's ABC. Oh, that medicine has changed now. When they arrive there, they check the pocket. Before the pulse, I can assure you, this is not an exaggeration. Because when you check the pulse, you are going to charge already. So you can't charge a person with no money. They check the pocket. They don't do ABC. I don't know what to call it, but it's firstly medical aid, or it's M. Medical aid, credit card C, cash. So it's MCC, not ABC. Medical aid, credit card, cash. If they are not there, they go away. I got very angry when the former head of health services in the Western Cape, Professor Greg Housen, has just retired, I think about 2 years ago. He has even tried to negotiate and said, look, when you come to the scene of accident owning a private ambulance, you are using petrol. When you find that that person doesn't have medical aid, it belongs to the state, please, just transport them, we'll give you money for petrol. Because you have already wasted it anyway. They refused. Doesn't work that way in business. They refused. So we want to change it by law. And also change what metros are doing. Metros have got a tendency of stopping here and say, I can't face the patient the other side. It's a different metro. Yes. That must also stop. And so I'm being threatened with a court case. I've already been told by the Private Ambulance Association, I forgot what they call them, BIAS or something. They've already written me a letter quoting Section 3 of the Constitution that I'm interfering with their right to conduct the business because I'm destroying their brand by the same color. Now, I get surprised. I want to ask a question as soon as we meet with them. All the taxis in New York are yellow, but they are owned by different companies. None of them have ever complained. All the taxis in London are black, but they are owned by different companies. When you get license for a taxi, they said, okay, fine, we give you a license, but you know that the condition is that it is yellow. All the people who build in these gated communities, they are given a theme. That your house cannot be this color, it can't look like this, it can't have this, it can't have that, and they agree. But when you want to impose that in health, they say we are interfering with, no. There has to be some measure of control. So those are the acts that we are going to change, all of them, in order for any child to happen. Thank you very much.